from LPCA. Thank you for joining us this afternoon for the third session on FQC corporate compliance. Our presenter this afternoon is once again Bill Carberry from Peak Performance Physicians, and our topic for today's session is compliance on conditions for the HRSA 330 grantee program coverage. This session will be recorded and available on the LPCA website following the call. As we will have all the phone lines muted during the session, please feel free to type in any questions you may have, and we will answer them towards the end of the session. The handouts are available for download under the handouts icon in the control panel. Thank you, Bill. You may now begin the session.
Well, good morning or good afternoon. It is 12:01, so good afternoon. Thanks for participating. Today's session is going to be a little bit longer than normal because we are going to go through all of the 19 different questions that are asked by HRSA for the program requirements, and we're going to go through them in a bit of detail. I'm going to, as I always do, is that I keep the first few slides are all the same, just so you get used to see them. But our presentation goal is to go through all of these 19 requirements. Now, one of the handouts we gave you was a questionnaire where you can do a gap analysis or a risk analysis, whatever you want to call it. And one of the things that I just want you to be aware of is that as you're going through these questionnaires, it's more important that you get an answer and less important is what the answer is. What the answer is becomes important later. But first you want to make sure that you get everything answered that you can, because then from those answers you're going to develop your compliance program for doing the corrective action plan of what you need to do and what you need to do and who needs to do it, and then that becomes a part of your corrective action plan that you take to your committee. And then when you build your corrective action plan, you're going to build it with who's responsible, when they're supposed to be doing it, and then that becomes a standing agenda item for your compliance committee. So initially, as you go through these things, is if there is a no answer or we don't know or we're not sure, it's okay to have that, because what we then want to do is to go back and see how we need to answer those. So be very mindful that frequently we get just hung up on, oh, we said no to this, now what do we need to do? And what you want to be mindful of is on this initial phase, what you want to do is you want to get the thing answered, and then you can start targeting what needs to be done. Now, this presentation comes directly from the HRSA website. They have the 19, there are 19 program requirements, and that click right there takes you right through it, or you can just go to the HRSA website and look under Health Center Program, and you get these program requirements, and they are completely outlined. Not in as much detail as we're about to go through, but they are outlined. Now, they're brought into 4 different parts. The first part is there's a need, services, management, finance, and governance. And the needs one we're going to go through right here is very quick. It only has one thing, which is the needs assessment. On the services area, which is the B part, is that you have 2 through 8, required and additional services, staffing requirements, accessible hours, after hours, admitting privileges, sliding fees, quality improvement. The C, which is the management finance, is the management staff, contractual affiliations, collaborative relationships, financial management control, billing and collections, budget, program, and scope of project. And then governance is board authority, board composition, and a conflict of interest policy. So those are basically the 19 requirements that you have just in a bullet form. The devil is now in the details, as you always know. So we're just going to launch into this because it is long, is that the needs assessment requirement is the health center demonstrates and documents the needs of its target population, updating its service area when appropriate. Now, the health center performs periodic needs assessments, and they don't define what periodic means. I have heard and read between 1 and 3 years. So it's you will define what in your compliance plan, what is the periodic needs assessment, how frequently you're going to do it. The assessments, you need to document the populations, and then the assessment includes population to primary care physician ratio, population below 200% poverty line, percent of uninsured, proximity of providers who accept Medicare, Medicaid, and health indicators, diabetes, hypertension, and so forth. So those needs assessments must be done, and so when we have the questionnaire, it says, do you perform a written needs assessment? The first thing is yes, no, we do that. And then it's going to be who does it, how frequently, and then what data do you use? Do you have a defined service area? And just going through the questionnaire and getting those answers. The second part, the B part, services, is the required and additional services. The health center provides all required primary preventive enabling health services and additional health services as appropriate and necessary, either directly or through the established written arrangements and referrals. Now, one of the things that you'll note is that our Section 330, we have all of the acts and where you're going to find these things in the Public Health Service Act, so that you'll be able to find where it is that you're supposed to have this. And at the very end, as always, is that I put references with links. Ensures that the center directly providing or has written arrangements and referrals in place. Now, I'm going to caution here, because if you have those written arrangements, you need to make sure with your attorney that those arrangements meet all of the Stark regulations and that there's no problem with that. So this one's a kind of a twofer, because it's going to come back into financial relationships later, but also just put your mind here is that when you have these arrangements, you have to just make sure that they do not violate any Stark laws or Stark amendments, so that you can stay out of trouble there. All the services in the project must be reasonable, accessible, and available on a sliding fee schedule. We have a sliding fee schedule later that we discuss, but it is on a sliding fee schedule. And then you have to have a formally documented written memorandum of agreement or memorandum of understanding that at a minimum describes the manner in which a referral will be made. Now, I already know that some people, some centers provide psychiatric services through, it's not a full-time basis, they have a contract physician. Some have OB services through contract physicians. Some have contracts with hospitals or with other facilities to provide them with the services. Again, make sure that it is formal, it's written, and that it has been reviewed by your corporate counsel to make sure that it meets all of the Stark regulations, so that there's no antitrust, anti-fraud, anti-kickback. All right. The next one is staffing, which the health center maintains a core staff necessary to carry out all required primary, preventive, and enable, and those are all of the sections below there. You can read those. Now, let's go to the next part. The composition and numbers must support the health center's clinical performance goals and ability to provide the required additional services. All health center providers are appropriately licensed and credentialed and privileged to perform the activities and procedures detailed within the health center's approved scope of project. I think one of our handouts that we gave you was on the requirement sources, and I think this is it, and it should come up for me here. And these are those are the resources to find things. Let's see what this one is. The primary notice for the. These are the primary notices. I did. Christine, when I sent you the thing, I knew we had one. I was missing one. This is the one that I'm missing that I'll just go ahead and send that to you after, because it does primary source. It tells how you have to do the primary source validation and who requires that. So I will send that to you secondly so that you can get it out to the folks. That was the one that was missing. You know, we sent the wrong one. I sent two of the same thing once. So the insurers, and so you have to make sure that they're credentialed appropriate and that you have the appropriate for what you're offering. Is that you can't, if you say you're offering psychiatric services, is that you need to have someone who is credentialed in that. If you're offering the various services, is that they need to have the appropriate document. This is where that credentialing checklist comes from. You can get that one on the HRSA Gov side, but I'm going to send it out again. And then the staffing should be culturally and linguistically appropriate for the population. If you are serving primarily a Hispanic population, you need to have someone on staff who can speak the language of the people you're serving. Therefore, nothing is missed in a translation of what you're trying to get, the information you're trying to get. The next item was item 4, which is then the accessible hours of operation. And the hours of operation include, the standard says it services times and location to be accessible and meet the needs of the population, or provide appropriate to ensure the access. Should offer some appointments for after normal work hours based on input and feedback from patients. And again, you see, you can take this and you can go backward and say, well, as part of our needs assessment, we've got an input feedback from the patients, and this is what they need. They need the early morning hours, or they need late hours, or they need weekend hours. And then you see this falls back into the first one, which is your needs assessment. So when you look at these things, they don't all stand alone. They also have the possibility of linking to something else. The locations should be available to where your population is. When I worked in Southern California, and we had a lot of migrant worker programs in Southern California, is that a lot of it didn't do any good to have an FQHC in downtown Los Angeles. You need to be up in Ventura County, where the fields were for the migrant workers. In Florida, we have the same thing here with our areas where we have people who do the vegetable as well as the orange picking, is that we need to have the area, we need to have it in that area and not located away. Also is that the hours of operations for, and again, they give an example, services offered at migrant camps by grantees for targeting migrant and seasonal farm workers. We have that here in Florida quite a bit. I know that in parts of South Louisiana that you all have the growing for rice and so forth. So I just make sure that you're in a place where you can demonstrate that you put it in the best places possible. After hours coverage and this one gets a little tricky because everybody jumps on this immediately and says, oh my gosh, we've got to have it. After hours coverage is clearly defined arrangements. So it's clearly defined. And so you need to have an arrangement if you have someone, whether it's an on-call, whether it is going to an emergency room, whether it's going to have telephone access, who can to a nurse practitioner, or to the emergency service. But you need to have that very formal. It needs to be very clear that you do have that arrangement and that your patients are aware of that. After hours, call this number. After hours, go to the emergency room, or call this clinic, or go to this clinic. But you have to have the specific arrangements, and your community, it depends on how it's set up. There is no definition, so it just depends on how you do it. But remember, what the requirement is that you have professional coverage for medical emergencies during hours when the center is closed. And then we go back to the questionnaire is, do you have that? Yes, no. If no, then what do we need to get that? And these are just some of the arrangements. So I'm trying to think in both in terms of the questionnaire that you've got as well as just what the requirements are. Hospital admitting privileges. Health center physicians at one or more referral hospitals or other such arrangements to ensure continuity. You may have an arrangement if you have a hospital in the area that has a hospitalist group or an emergency room group. So your physicians don't necessarily have to have admitting privileges, but you have to have someone who has admitting privileges. So you have to make sure that those things are available. You have to, all health centers must have either admitting privileges for the physicians or some other arrangements. And again, when you get those arrangements, make sure you run those arrangements through your corporate counsel just to make sure that they are that they meet all of the STARK and the anti-kickback and the anti-referral statutes, as well as this one. And then, again, it says arrangements for hospitalization, discharge planning, and tracking. So it's not, a lot of people will look at this and say, oh, we have to have it. Yes, we have to have it, but we can have it through a contracted arrangement. And again, I'm going to strongly urge that your corporate counsel review those. Number 7, we had talked about sliding fee discounts, and here are some of the sliding fee discounts. System must provide a full discount to individuals, families with annual incomes at or below 100% of the federal guidelines, and for those with incomes between 100 and 2% of the poverty, fees must be charged in accordance with a sliding discount. So it has to be a written program so that someone can look at it and see what it is. No discounts may be provided with people with incomes over 200% of the federal poverty guidelines, and no patient will be denied services due to an individual's inability to pay. On the sliding fee is that I want to just come down here to this right here. Is this website right here tells you what the guidelines are, and then for you budding little compliance officers, it must be updated annually. So as a compliance officer, you're going to say, we have it, and then the next question is has that been updated annually? Because as a part of the requirement, it is saying that it should be updated annually, and that the patients have to be notified that there is a sliding fee discount. Okay? Quality improvement and insurance plan. And yeah, I'm sure you all have some sort of QI/QA program. This is where it says you have to have it. Again, you've got to have the program that gives you what must include. You have to have a clinical director whose focus and responsibility to support the quality. You have to have a periodic assessment of the utilization. It doesn't say how frequently that is. So as a compliance officer, as a compliance program, you will say this is how frequently it is. It's to be conducted by physicians or other licensed under the supervision of physicians based on systematic collection and evaluation of medical records and identify a document necessity for change in the provision of services to where the health center and result in the institution of such change where indicated. We have more under this number 8. And again, it says on a regular basis. So just highlight the fact that it says that it's on a regular basis, and you're going to get to determine what regular basis means. And then you're going to have all of these folks. And again, if you're doing this through a contracted basis, is you need to make sure that you are that you're covered under the anti-fraud and the anti-kickback. Okay, key management staff. Fully staffed as appropriate for the size and needs of the center. And if you change the director or CEO, is that you have to notify, and it has to be approved by HRSA for the change of the executive director or the CEO position. Management staff, again, it says that it has to have that. The management team, which may include a clinical director, chief operating officer, chief information, as appropriate. And some of you all are small, and you don't have to have all of those. Is that I've been in places where both the CFO and the COO were the same person, and the chief information officer and the billing and the collection person were the same one. So it is, you're the ones who are going to determine it. It just has to be appropriate for the size of your team. If you're seeing 10, 15,000 patients a year, you may need a more complex office than someone who's seeing 400, 500 patients in a year. And I know that makes no sense because you all see more than 500 patients a year. But I'm just saying is that if you do have a very small, it's one thing. If you have a very large, it's something else. Contractual affiliates and agreement. What is the first thing we need to know about those things? Is they have to be reviewed by your attorney to make sure that they're all the anti-kickback and the anti-fraud things. Just make sure that all of those agreements are done by them. And it says that they have to meet the health center program requirements. This is the section that it does in there. And you just have to also have to make sure it meets the conflict of interest standards. Let me see if this, yeah, the conflict, whoops, there we go. The affiliate agreement must not threaten the health center's integrity, meaning you can't have one that is so, that you have to pay so much for that you're never going to get enough money back to support yourself. It can't compromise compliance with any of the program requirements and the limits, and you can't limit the health center's autonomy. This is why, because of those things right here, these are the ones that you need to make sure that it's at least run by your corporate counsel to make sure everything is okay. And then part of the thing is, part of that contract or that agreement says that they agree to comply with the standards. That's very similar to a business associate agreement, or as we've talked about with some of the contracts that you have with your outside vendors, to make sure that they say that they're going to comply with any of the Medicare rules and regulations on hiring people who have been debarred or banned from the program, and that they have a business associate agreement and so forth. So it's nothing new. It's just something different that we just want to make sure that we have it. And again, think back to what I said earlier. Don't panic if you're not, because the whole concept of the compliance plan is to find those areas where you're not in compliance so that you can get in compliance, so that you have a, therefore, very active program. Probably most of you all of these agreements are going to be fine. You may just find one that looks a little wacky, and then what you do is you just deal with it when you run across them. The collaborative relationships, the same thing. It's just the same process, is that you have with other appropriate providers and organizations, including other health centers, public housing, primary care guarantees must show how residents are involved in the administration, in the SAC application, and so forth and so on. So you just have to make sure, again, that any collaborative relationship that you have, you're not required to have a collaborative relationship, but if you do have them, then they have to meet these guidelines. And once again, is that I refer you back to your attorneys to make sure that it does meet those criteria. Financial management and control policies is that you have to have internal policies. You have to have accepted GAAP policies, which is generally accepted accounting principles. And then it says it assures an annual independent financial audit is performed in accordance with federal audit requirements, including submission of a corrective action plan addressing all findings, question, cost, reportable, and material weaknesses cited in the audit report. Now, as a compliance officer, the first thing you want to know is, do we have one? And if we do, how frequently do we have them? And then thirdly, where are the footnotes and so forth on the material weaknesses on the audit report? And then this becomes the basis of, again, your corrective action plan. If there's nothing you have to correct, you don't have a corrective action plan, and you wait until next year to get the second audit or the next audit. And again, it just gives a little bit more. It gives a little bit more definition of what we need to find here. The auditor's report, including an auditor's opinion, financial statements, notes, and required communication from the auditor, and any management letter issued by the auditor or statement signed by an auditor to the health center that no management letter was issued. So if you don't have it, if you don't have any, if you don't have a letter, then somebody has to tell them that they don't have a letter, because you're supposed to have a letter, and if you don't have a letter, tell them you don't have the letter. And then any material weaknesses that are identified, this was their note, must be addressed by the health center. So again, that's going to be just something you're going to start with. Do we have that? Are they done annually? What does that annual report look like? And are there any areas that need to be addressed? Billing and collections. The health center has, you have an obligation to maximize your collections. So therefore, you need to have written billing, credit, and collection policies, and that you have to have in place to maximize. Health centers must bill Medicare, Medicaid, CHIP, and other must. And I think we talked last week about will, should, must, may. When you see must, that means you have to. And so you are required to bill any third party, including Medicare, Medicaid, CHIP, in order to receive the services or to get payment for the services. The next is the budget requirement. You're supposed to have a budget. And then this right here is very specific to you all, the SF 424 budget justification and staffing profile and income analysis form 3. You're simply looking for, do we have those, and do we have the budget, and is it consistent with delivery, how reimbursement will be maximized for third-party payers, and how proportion of requested federal grant funds is appropriate to other sources of income. So this, you have to have a budget. Again, think of, you're not a chief financial officer, you are a chief compliance officer, and all you're asking there is, do we have one, and does it meet the criteria? If it does, move on. If it doesn't, what do we need to do to get compliant with this? Program data reporting systems. Has systems correct and organize data for program reporting, which supports management decisions. You have an MIS that can collect the data. It submits the accurate and timely reports as required. Again, are we submitting what we're supposed to be submitting when we're supposed to be submitting them? That's your major, question. The quality of that information initially is something you're just not going to deal with. You're only going to deal initially with, yes, we are, and then you can deal with the quality of those later when you run out of things to do. The health center performs a complete and financial performance measures form with the annual application, and these are program requirements. 16, the scope of the project. The center maintains its funded scope of the project, including increases based on grant rewards, Section 330 scope of project, total grant-related project supports, 5 core elements, services, sites, providers, target population and service areas. Changes in scope may affect eligibility. Changes in scope may affect eligibility and coverage, and significant changes in scope must be approved by HRSA. And this is where the scope of project, the policies are there. Now, I have gone to some of these links. I have not gone to all of these links. Some of them say that the file is not found. I just simply go into the, I go just into the search bar within there, and I do scope of project, HRSA scope of project, and all of these old things, and all of the archive things, because they're archiving things frequently, it appears, but they are still out there. and then they maintain the approved and funded scope of project in terms of number of patient service visits. So in here is that the terms of the number of patient service visits and services available. Someone should be keeping count of those things to make sure that you meet, and as a compliance officer, all you want to know is, do you meet, do you not meet? If you do not meet, what do we got to do to meet? Okay. 17, 18, and 19 is the governing body. This one gets really very detailed on what they want. And here are the requirements: is that you hold monthly meetings. They have approved the grant application, the selection and performance evaluation of the CEO. This is probably the place where I've seen more issues, is that the performance evaluation on the CEO is not done frequently, or is not done frequently, or not done at all, and just need to make sure that that happens. The selection of services and the organization, measuring the evaluation of the progress toward meeting the goal, and the establishment of general policies for the health center. Board authority meets monthly, reviews and approves the budget, so that's just a rehash of those. Conducts, and it says, an annual review of the CEO's performance, with clear authority to select or dismiss the current CEO if needed. Reviews the hours of operations, the goals, and long-range and long-term planning for the health center. It also reviews the mission and bylaws as necessary on a periodic basis. I do not know what that means. You get to set that up. That's a 1 year, 2 year, 3 year, 5 year. Frequently in other healthcare entities, the bylaws are reviewed on a semi-annual to a tri-annual every 3 year basis. Receives information, make sure that they're getting the information that they need. And again, for you report to the board that they are or are not getting the information. You are not the one who's responsible for seeing that they get the information. That is to the CEO. So you're just simply saying it is getting the information. And the quality of that information then becomes something that you look at when you run out of things to do. It establishes general policies, personnel, health, fiscal, quality improvement. So all of your policies and procedures need to be approved by your board. We did a review of one, and they had a great deal of policies and procedures, wonderful, absolutely wonderful, and none of them had been approved by the board. So the first thing was the board had to go through and approve the policies and procedures. For public center grantees, and I don't know if any of you all are that, is that you have a record of form, a co-applicant agreement, that the roles, responsibilities, and delegation any shared or split responsibility between the public center and a co-applicant board. I'm not sure if any of you all meet that criteria. If you do, then you need to work with your corporate counsel to make sure, as well as your CEO, just to make sure that you meet those requirements. Number 18, the board composition. In the board composition, you have to have at least 9 and no more than 25. So even the smallest organization has to have 9. Non-consumer members of the board shall be representative of the community in which the center service area is located and shall be selected for their expertise in community affairs, government, finance, banking, legal, trade unions, and other commercial or social services within the community. And no more than 50% of the non-consumer board may derive more than 10% of their annual income from the healthcare industry. Okay, so let's work through that one for a second. No more than, you've got 9 members, so half of 9 is 4.5. So 4.5, no more than 4.5, can get 10% of their annual income from a healthcare industry. So if you put a hospital administrator on and you put a nurse practitioner on, and they get more than 10%, that takes up 2 of those 4.5 spots. So when you're looking at your board composition, is to make sure that it meets this criteria. And again, as a compliance officer, you're simply asking the question, do we have more than 9 and less than 25? What is the composition, and then what percent of the board members gain their income from the healthcare industry? See, I don't think you could put me on your board because I gain most of my income from the healthcare industry. So you just have to think about who you're putting on. 51% of the board members must receive patients at the health center. As a group, the patient consumer board members must reasonably represent the individuals who are served. There's no established ratio for board members to population served. However, board composition must be reasonably representative of the populations being served. If you're, health centers with approved waivers only, appropriate strategies are in place to ensure consumer patient participation. Given a board is not 51% patients in the direction and going government. So this is a place where you come in to make sure that it does do that. Health centers that receive their section of 3 through 2 or special populations and are not eligible for waiver of the board includes representation from special population groups, an advocate for the homeless, director of Migrant Head Start, or formerly homeless individual, and the board's still 9 between 25, and it's just based on what you, based on the diversity and complexity of your organization. Just reiterating all of those things. And then this is the last one, which is a conflict of interest. The health center bylaws or written corporate board approved policy includes provision that conflict of interest by board members, employees, consultants, and those who furnish goods or services. No board member shall be an employee of the health center or an immediate family member of an employee. And the chief executive may serve only as a non-voting ex officio member of the board. So, having said that, your question as the compliance officer is, do we meet those? And right now you're looking yes and no. You're not looking for any qualitative, yes we do, no we don't. And this is a pass-fail. Every question is answered yes, you ignore for now, and you go and you put the no's into a bucket that said this is what we need an action plan on. Okay? And you just go through. More on the conflict of interest. The bylaws and other policy include a conflict of interest provision. No current board members is an employee, and the CEO program does not participate as a voting member. Health centers conflict must address, if you don't have this conflict of interest policy, it has to address closure of business and personal relationships, including nepotism that create a conflict of interest, extent to which a board member can participate in board decisions where the board member has a personal or financial interest, using board members to provide services to the center, board member expense reimbursement policies, acceptance of gifts and gratuities, personal political activities of board members, and statement of consequences for violating conflict of policy. And this is just more of the same. And then, as I promised, is down at the bottom is that I'm going to give you the guidance and enforcement and the health center program statute. There's the grants regulations, the program regulations, more program regulations, Office of the Inspector General, HRSA, and then the Office of Civil Rights, and that's primarily where HIPAA is the Office of Civil Rights. And in a mere 45 minutes or so, I think we've been able to sort of wander through this and get to, in 30 minutes we've been able to get to it. I'm sure, I feel very certain that we have more questions than I can perhaps answer. And at that, Christine, I'm going to throw it back at you, see where we go from here.
Okay, thank you, Bill. If anybody has any questions, now would be a good time to enter them into the questions box. We don't currently have any in queue. I did want to ask you, Bill, the FQHC CFC questionnaire draft was included in the documents that is available to attendees. So did you want to go over the questionnaire at all in any level of detail?
Well, we can. If there's no questions, we can go over that. It's just basically exactly what we went over, but it's in question form. Just as an example is any board member, an employee of the program, or an immediate family member of an employee. So it's everything that we've just done, but it's in complete question form. I'll be more than happy to go over that. It's only about 5 it's only 4 or 5 pages long. It's only 16 pages long.
16 pages.
It's only 16 pages long. So I gave that to you all. That's a place where you can start on this aspect of the, we had promised you questionnaires in the beginning, and this is the first one.
Okay, fair enough. I don't think we need to go over the
16 pages.
Right, but I did want everybody in attendance and for those who are taking notes and some presentation slides, et cetera, back to others in their health centers to know that they are free to use that questionnaire as they are answering the questions on their own center's compliance. Very good reason.
And on that questionnaire, I will just say one thing about that questionnaire, which is on the questionnaire is that it does have the things for doing the primary source verification that I was talking about earlier that I had left off. It's on that questionnaire. It's on it's page. It's
okay.
I keep getting it. There we go. Here it is. And these are all of the things coming down right here. The primary and secondary source validation, and it tells you who and what, where you get it, and what you have to have is on this page 4 and page 5. Maybe that's why I didn't include it.
Okay,
all right.
A couple questions have come in.
Okay.
The first one is, we have a psychiatrist on staff. Does he also need to have admitting privileges at a hospital?
You have to have, if you provide the service for a psychiatry, is that you have to have some sort of arrangement for admitting. He does not have to have it specifically, but if someone does need to be admitted, how is that going to happen? And you have to have an arrangement in that for that. So no, he doesn't have to have it. However, you have to have an ability to admit a psychiatric patient.
Okay, and the next question is, under credentialing, are you required to maintain a copy of the provider licenses as well as verify licenses, or will having only verification on file suffice?
Okay, credentialing. Let me go back to, hang on a second. Yes, you're required to have it. I'm going back to this draft again, going back to this compliance questionnaire. All right. Can you all, Christine, do you all see that needs assessment up there on compliance plan development?
Yes.
Okay. All right. On page 4, it says, do verification comply with the following listed table below? Also contemplates 2 types of verification, primary source and secondary. And this section tells you what you're supposed to have. Verification of licensor, primary source is an independent contractor, other RNs, and each one goes through what you have to have for each of those. Yes, you need to have a credentials file on, you have to have a credentials file on everyone, and as you'll see right here on this line is that at least every 2 years you do the re-credentialing to make sure that everybody's who they say they are. Now, we're always doing, as part of that credentialing file, you're always making sure that none of your professionals have been delicensed or debarred from either acting as a nurse practitioner or a physician. There's no blemishes on their record. And then secondly is that none of them have been excluded from the program. But this whole section right here, goes through what you need to have, and then do you have it? You have the staffing profile. Do you have the all of those things for the credentialing? So yes, that credentialing is yes. You have to have it.
Okay, thank you. And the next question is, what is HRSA's thought on having electronic files compared to paper files?
They don't have a thought. It just says that you have to have the files.
Okay, thank you very much for those of you asking questions and Bill for answering them. We have approximately about 10 minutes more if anybody else had any questions. Otherwise, we are happy that you have joined us today, and we look forward to having you with us again next month for our next installment of the Corporate Compliance Institute. And next month we will be talking about compliance requirements for the 340B program. There have been a number of changes in that, and so you won't want to miss that presentation. Once again, we have recorded this session as well as the first two sessions, and they are all available on the LPCA website. And handouts for those sessions as well are also available on the LPCA website. So thank you for joining us this afternoon, and we look forward to having you with us again next month. Have a good day.
Thank you, Christine. Thanks, everyone.